start by thanking the Yemeni Urological Association for inviting me for this interesting topic, and the Arab School of Urology for hosting also the symposium. I would like to thank Dr. Hamad for his comprehensive overview of the evaluation of male infertility and highlighting on the very important topics about the causes, different causes of male infertility. So it's actually today lecture. My lecture will be about hormonal and medical intervention in male infertility, what's real and what's hype. And this is actually a huge topic that can be divided over so many lectures, like tons of lectures. So I'll try to gather all the informations, the evidence, and present it to you. I might take a little bit extra time, so if you allow me to do that, I will be grateful. So just to speak the same language. So definition, Dr. Hamad have described the definitions. However, I would like to highlight so we can speak the same language. So infertility can be divided also based on the cause of male infertility as either infertility of non-origin, as Dr. Hamad have said, genetic varicocele endocrinopathies or different, or female of unknown origin, infertility of unknown origin. And this can be divided according to the semen analysis into either idiopathic male infertility, and here the semen analysis is usually abnormal, ranging from azoospermia to oligoathenoteratospermia, and infertility of or unexplained male infertility. And here the semen analysis is normal and there is no underlying factor that we can identify in the patient evaluation. So this is in general. So when we talk about in the future different kind of treatment, we know what we are talking about. So today's categories of male infertility can be divided either into first of all, always remove fertility damaging drugs and habits, specific treatment, and here we have underlying causes as endocrinopathies, genitourinary infection, and ejaculatory dysfunctions, or non-specific, as Dr. Hamad has mentioned, empiric treatment, and this is divided into either endocrine treatment or antioxidant treatment. So we'll start by the removal of fertility damaging drugs and habits, and this is very important because it's very important before starting treatment to anybody to make sure that there is no underlying cause that we can eliminate before we go to this. And as a urologist, it's very important to know what prescription that because many of the prescription that we write can really affect male infertility, and starting with the finasteride or dutastrides, which is very commonly used for patients with prostatic enlargement. And I'm presenting here one of the studies, very interesting studies that has been published in 2007 by Amouri and his colleagues. It's a randomized controlled trial, including 99 volunteers, has been divided into either using finasterides or dutastrides and comparing them to placebo. And it is done over a long period of time, around 2 years of time. And it's very interestingly that we can see that these patients have really decreased in ejaculatory volumes, as you can see here. And this was initially in the finasteride, but dutastride has been persistent over time. Also, it has been shown that patients with using these medications have persistently decreased in the sperm motility, and this is persisted over time and in both finasteride and dutastride. Also, there is decrease in sperm count and concentration, both are affected. It is more in the initial period of time, but some patients, around 5% of the patients, will have significant drop of their sperm count and concentration. Also, there are transient decrease in sperm concentration, as I mentioned before, and 5% have drastic drop in their total sperm count. One of the other medications that we frequently use for patients with premature ejaculation is SSRI, that is being used for premature ejaculation. And I'm here representing another study that have been done by Schlegel and his colleagues, and this study included 74 patients that has been recruited from the community and compared to 44 controls, and we can see that all sperm parameters have been dropped, including sperm count, motility, and sperm morphology. Also, sperm function test, including DFI or sperm DNA fragmentation, has significantly increased in patients using these kind of medication. It's not only that the parameters was always that the longer the duration that you use these medication, the more effect that we can see on sperm parameter and DFI. Also, it is not only, as I mentioned, the sperm parameters, also DFI has been shown that it's been affected. And even here in a very short duration, as we see in this study done also by Schlegel's, and here they use paroxetines, and in paroxetine here, they have seen, because only small time, there is no effect on semen analysis. However, the DFI has significantly improved from almost 13% to around 30% over just 5 weeks of time. Also, it's well known that these patients have some effect on ejaculatory functions and erectile dysfunction. So it is well known that it can cause delayed ejaculation up to anejaculation. And the proposed mechanism may be due to impaired sperm transportation, serotonin, increased prolactin secretion, which will be reflected on gonadotropin-releasing hormones, and lower LH and eventually lower LH and FSH release. And also, it might produce or generate free radicals. And the recommendation, if possible, because these are usually psychiatric patients, some of them are psychiatric patients, if you can stop or change, consult the psychiatrist and ask him to change these medication. Painkiller is very commonly used in the community by urologists, renal colics, or others. It's very commonly used, and studies have shown that up to patients between 26 to 34 years have around 8% usage of this kind of medication. It have different kind of effects, and usually it will cause inhibition at the level of the higher levels at the hypothalamus and the pituitary both, which eventually lead to drop of the gonadotropin, including the LH, FSH, testosterone, increase in prolactin, and eventually also lower libido, effect on erectile functions, and eventually poor sperm parameters. And it is very interesting that these kind of medications always dose dependent. The longer that you use these medications and the higher the dose, the more the effect that you can see on sperm parameters. Also, the recommendation here will be try to stop these medications if possible. And this is another study here that has been done by Safarjid and published in 2013. It showed that all sperm parameters has been significantly affected while using these kind of medications, and also sperm DNA fragmentation has been significantly affected by using these kind of medications. Recommendation: stop or switch if possible. Others, also one of the others, the medication that we commonly use in urology is alpha blocker. It's well known it causes retrograde ejaculation. Others list of medication that you can go through it. I cannot mention all of them, but there is a lot of medications. It's important to go through these medications. Importantly, as Dr. Hamad was saying, timing and frequency of intercourse before embarking on starting treatment. Make sure that they have the proper timing on the pre-ovulatory times. Usually, we recommend them to have every other day intercourse. Make sure that eliminate all other risk factors as mentioned before, like a history of fever. Make sure that there is no history of fever over the last 2 to 3 months. Smoking, use of lubricants, KYs, avoid heat exposures, alcohol consumptions, all these, overweight, all these, try to eliminate before you start patient on treatment. So guidelines mentioned that these factors are really can affect, according to the EAU guidelines, it really can affect the sperm parameters, and it's better to ask and avoiding or improving these lifestyle factors can improve semen parameters. Both in the also in the ASRM and the American Urological Association have mentioned the same regarding these risk factors. So finish the remove fertility damaging struct, go to the specific. And this is one of the nice things, because as Dr. Hamad mentioned, it usually have a very good effect. I cannot go through all of them, but I will be focusing mainly on the endocrinopathies. And one of the main things we discussed earlier is the hypogonadotropic hypogonadism. As mentioned before, it can be either in the level of the hypothalamus or in the level of the hypophysis or the pituitary. And the level of the hypothalamus usually due to the effect of the GnRH secretion, what we call it Kalman syndromes, or in the hypophysis will lead to drop of LH and FSH. Treatment is simple. Usually gonadotropin replacing hormone in a pulsatile fashions will go through this, or giving gonadotropins or giving testosterone. The main thing that you have to consider here is not only correcting the testosterone level, because correcting the testosterone level can affect fertility if it's not corrected through a physiological pathway. So if you give gonadotropin releasing hormone or gonadotropin, you will make the testes produce the testosterone directly, which is very important because the concentration of the intratesticular testosterone is much, much higher than the level of the testosterone in the blood or the plasma. It's around 60, 70 times, and some studies saying even more than this. So correcting the testosterone by giving testosterone, it can improve the virilization, but it will the patient fertility will not be will not help regarding his fertility. So what is the best protocol? we can give the pulsatile gonadotropin is very difficult. It's usually given subcutaneous. It has to be titrated every 120 minutes. It's very, very expensive. The most commonly used medication is the HCG and the FSH, whether the component of the human immunoposed gonadotropin in a dose of 75 to 150 international units subcutaneously three times weekly. Which one to start first? There is a lot of controversy, and there is a lot of studies saying that. One of these studies is the studies done by Kobri, and in this study, he divided patients with hypogonadotrophic hypogonadism into different categories and looked to the effect of these medication on induction of spermatogenesis and the time frame that has taken for these medication. And if you can notice in this, when you use the combination from the beginning of HCG and FSH together, about 90% will achieve spermatogenesis. However, if you look into the timing for a spermatogenesis, if you started only with HCG, it take much longer time. If you started sequentially, it will take longer time. So you can start by HCG, then add FSH, or you can start both of them at the same time. Induction of spermatogenesis, according to the pituitary causes, usually having much higher chances of having induction of spermatogenesis reaching up to 90 to 100%. Hypothalamics, little bit less, up to 80%. Very important to observe the testicular size in these patients. Initially, you measure the testicular size and document that, and then follow up after treatment, because this is considered, as we can see, one of the main prognostic factors that can tell you that this patient is very well responding to the treatment if the testicular volume is improving. So this is one of the important things. Induction of spontaneous pregnancy, this is also very important. This is the study of Zini. Around 80% of patients with pituitary factors can reach spontaneous pregnancy. Up to 60% of patients can reach in hypothalamic causes spontaneous pregnancy. And another study by a group from Turkey looked into the different methods of pregnancy, not only spontaneous, reach up to 70%. He didn't define hypothalamic or pituitary, and around 12% or 12% reached through IUI, IVF 15%, and patient who eventually underwent TCXE was only 4%. So as we mentioned before, testicular volume. Prognostic factors, the most important is testicular volume is the key predictor. History for cryptorchidism, and you have to know that these patients can very commonly present during childhood with cryptorchidism. It's very important to pick this up early and correct it early in their childhood, and this can really reflect on their future fertility treatment. Very interestingly, as we mentioned before, prior to testosterone treatment was a negative prognostic factor for fertility outcome. And this is very important because many of our colleague endocrinologists usually treat these patients when they come with delayed puberty with testosterone replacement. We don't, as a reproductive urologist or andrologist, we don't prefer this kind of treatment. We prefer to start with an HCG because HCG will help the testes to start producing testosterone, increase intratesticular testosterone, and this can be reflected in their future fertility. And many studies have documented that. Another endocrinological factor, Dr. Hamad have mentioned during his talk also, the prolactinoma. It can be either micro or macro prolactinoma based on the size, less than 1 centimeter or more than 1 centimeter. And here, always the prolactin, as we mentioned, can you see here, have a negative feedback mechanism on the hypothalamus and pituitary both, leading to increased prolactin will eventually lead to drop of LH, FSH, and testosterone, and this will be reflected on the testosterone and spermatogenesis by stopping of spermatogenic arrest. Therapy plan, usually by dopamine agonist, and can be titrated. Usually we start with cabergoline 0.5 milligram once or twice weekly, and response follow up with a response with hormones. It's very important to monitor with MRI and check further hormone axis, including TSH and other kinds of cortisol and other hormones that secreted from the pituitary. It's important to refer these patients to neurosurgery if the prolactinoma is large, and usually we treat them, we don't refer them, but if it's a large and there is signs of intracranial increased intracranial pressure, it's important to refer them to the neurosurgeon or the ophthalmology if there is pressure on the optic chiasma and visual field defect. So guideline statements, also the European guidelines mentioned that secondary hypogonadism in adult can be effectively treated by subcutaneous HCG and FSH. And as we mentioned before, GnRH